This is my presentation on cultural competence guidelines in the field of ABA by Sylvia Gossard for SPCE 682, Section 821. The objectives of this presentation are to address some common diversity issues faced by many of our clients, to examine these within the context of autism spectrum disorder, and to discuss ways that we can be culturally competent with our clients, support their diverse needs, while considering and being respectful of their culture, background, and lifestyle. Cultural competence is an important part of providing services for our families. As Dougherty and Johnson address in Chapter 9 of Autism Spectrum Disorders from Theory to Practice, so much of what we know will be determined through parent interviews and cooperation. We must be able to bridge the gap of communication, building trust with our clients. Part of this is done through our own cultural competence. The textbook credits this definition of cultural competence to the American Speech Language Hearing Association, or ASHA. They define cultural competence as the knowledge and skills needed to address language and culture. This knowledge and skill evolves over time and spans lifelong learning. This is the ongoing self-education and self-assessment of our knowledge of other cultures, where culture is an umbrella term covering all the things that make our lived experiences and perspectives different, as well as shape the things that we find valuable. They offer a cultural competence continuum. Stage 1 is cultural destructiveness. This is explicitly discriminating or using harmful practices against a group of people based on their culture. This is intentional harm. These are the kind of interactions that fuel distrust of systems. This would include forced assimilation, subjugation, and rights and privileges for dominant groups only. The second stage is cultural incapacity. This could include policies or procedures that are harmful for diverse populations. This includes racism, maintaining stereotypes, and unfair hiring practices. The third stage is cultural blindness. This is the misguided approach of not seeing color. When we ignore color, we also ignore all the ways that diverse cultures encounter oppression and harm, and we fail to address or change things. This is equality versus equity. We don't all require the same things to have the same opportunity. This would include differences being ignored, treating everyone the same, and only meeting the needs of dominant groups. The fourth stage is cultural pre-competence. This is the desire to do better, regardless of success, effort is being made. This would be exploring cultural issues, being committed, and assessing the needs of organizations and individuals. The final two stages, cultural competence and cultural proficiency, kind of go hand in hand. Cultural competence would be recognizing individual and cultural differences, seeking advice from diverse groups, and hiring culturally unbiased staff. Cultural proficiency is implementing changes to improve services based upon cultural needs. Both of these are actively making successful changes to support diversity and acceptance. It's ongoing education and self-assessment, and applying your knowledge to your environment to create an inclusive and supportive environment for those around you. This should be our goal as clinicians. In Broadhead et al. 2014, they looked at 103 studies from the Analysis of Verbal Behavior and the Journal of Applied Behavior Analysis that focused on the verbal behavior of participants with disabilities to assess the level of disclosure by researchers of cultural and language practices for the participants. Of those 103 studies, only 9 reported the cultural background or language of the participants. Then Lee et al. In 2017 did a similar study looking at 3 years' worth of articles from behavior analytic journals like Behavior Analysis and Practice, Journal of Applied Behavior Analysis, and some other similar journals to assess the reporting of demographic variables. They looked at articles between the years of 2013 and 2015. Only 10.7% of these articles reported ethnicity, and only 2.8% reported socioeconomic status. Then, in 2020, Jones et al. Looked at the demographic reporting in the Journal of Applied Behavior Analysis from the years 2013 to 2019 across 552 studies. They found that 88% reported the age of the participants, 77% reported diagnosis, 73% reported gender, and 54% reported developmental and functioning level. 33 and 22% reported education level and test scores, respectively. But only 7% of the 552 studies, looked at reported race or ethnicity, 4% reported language, and 2% reported the socioeconomic status of the participants. It's difficult for us to be culturally competent when so little research reports these demographics. It is incredibly difficult for us as BCBAs to know what will be most effective across these different populations. Latinx individuals with ASD tend to receive their ASD diagnosis later than their Caucasian peers, and they are less likely to receive one-on-one services than other ethnicities. This is especially true when English is not the language that they speak in the home. There are also cultural and language barriers that can deter or prevent early diagnosis in diverse cultures. One study found that families in India noticed social deficits before they noticed language deficits, which differs from findings in the U.S., where Caucasian parents tend to notice language deficits before they notice social deficits. Another example of cultural practices preventing early diagnosis and treatment is the Navajo Society. They have a child first, disability second approach with their children. They celebrate the characteristics of the child that make them unique. They don't often seek a cure for children with disabilities because it is a part of their uniqueness. The stigmatization of an ASD diagnosis in non-white families can lead to an underdiagnosis of ASD by doctors and deter families from seeking a diagnosis or treatment in the first place. Cultural competence is ongoing education and self-assessment. Educating ourselves of the culture and ethnic practices of our client will help us to be respectful. Listening to the concerns of our clients' caregivers and keeping them involved in the treatment process helps build trust, and it helps us address skills that are socially meaningful for our client. Acknowledging and respecting cultural social differences. This might include what is culturally acceptable eye contact, what kind of expectations our client's culture places on their children, and possible religious practices like kneeling and Catholicism. While some of these skills might not be plausible for our client at the time, we can work up to it, building toleration and the necessary prerequisite skills. We can also help our client's family to accommodate the needs of their child to help them successfully participate, or at the minimum give them the skills to keep them from prohibiting the participation of their family members. Race. The prevalence of ASD is higher in non-Hispanic white children compared to both non-Hispanic Black and Hispanic children. Clinicians are also more likely to diagnose a Caucasian child with ASD than a child with ethnicities presenting the same symptoms as their Caucasian peer. These statistics suggest that people of color with ASD are underdiagnosed. There are a number of barriers to accessing treatment, like wait lists, the financial cost with and without health insurance, access to health insurance in the first place, and transportation. All of these barriers are worse for people of color. There's also a mistrust of providers and healthcare workers in general. Some of this comes from the historical mistreatment of people of color in the name of medicine and research. Some examples are the Tuskegee experiment, the Mississippi appendectomies, Madrigal versus Killigan, and Ralph versus Weinberger, to name a few. There are also a lot of negative experiences for people of color with healthcare providers, like discrimination and bias. All of these can prevent and deter people of color from accessing the healthcare and interventions that they need. Children engaging in maladaptive and disruptive behaviors, such as aggression, elopement, and property destruction or disruption, are at an increased risk of coming into contact with law enforcement, being arrested, detained, or incarcerated, having unsafe interactions with members of the community, and experiencing restraint, sedation, or hospitalizations for routine healthcare checkups and procedures. All of these risks are increased for children of color. So we have a population of people that is underdiagnosed, meaning that they are not accessing the necessary interventions and supports. They have increased barriers to access said support, and the symptoms of their undiagnosed disorder put them at an increased risk of harm. All of this in comparison to their Caucasian peers. People of color with ASD are an underdiagnosed, underserved, and unprotected population. First and foremost, we need to assess and address any biases or assumptions that we think we might have about our client and their family. If biases or prejudices are identified, we need to do our best to educate ourselves, and if we feel that we cannot provide the culturally competent care that our client needs with further education and training, then we need to help our client find a provider who can. Considering the negative history that people of color have with healthcare, research, and agencies of power, we will likely encounter some issues with trust. Our clients might not be the most receptive to our suggestions. We need to keep this in mind with our interactions. We can work to earn their trust through respectful interactions, listening to their concerns and desires, and keeping them as an active participant in the treatment planning. We should be doing this with all of our clients, but making sure that we are listening to what our clients are telling us that they value or need. Some common socioeconomic barriers for low-income families are a lack of health insurance coverage, the inability to afford treatment, and a reliance on public-provided services. All of these can stand in the way of lower-income families accessing treatment for their child with ASD. The prevalence of ASD increases with the increase of socioeconomic status, meaning we find ASD more commonly in individuals with higher socioeconomic status. In contrast, the prevalence of intellectual disabilities and childhood disabilities is excessive in lower socioeconomic status families, meaning that we find more intellectual and childhood disabilities in lower socioeconomic families. These statistics suggest a possible underdiagnosis of ASD in lower socioeconomic status families. It also suggests that an increased access to healthcare services and specialists leads to easier access to acquisition of an official diagnosis. Research in language acquisition relative to socioeconomic status found higher levels of language development and usage in higher income families. This same study also found increased language acquisition with higher maternal education. This suggests that lower socioeconomic status serves as a barrier for language acquisition in individuals with ASD. Considering some socioeconomic status and treatment. For our clients with lower socioeconomic statuses, insurance and costs will be a concern. We should ensure that we are only providing services and supports that their insurance will cover or that they can afford. Keeping the parents or caregivers involved in the treatment process is important for empowering the parent as well as acquiring their input in the treatments chosen, maintaining their assent. It is important that we are completing all of our paperwork thoroughly and in a timely manner. This will ensure that insurance continues covering their services. Over-documenting is better than under-documenting. Considering the client's home environment is important when determining the resources that our client will have available at home. We need to make sure that we are providing our clients with interventions that are plausible and low or no cost for our clients' caregivers to enact in the home. Transportation might also be a barrier for our lower-income clients, so helping them to access transportation assistance is important. Medicaid offers transportation services for doctor's appointments. This might be a plausible option. They might need fewer days of services with longer days spent in the clinic to help decrease transportation costs. They also might need help condensing therapies or finding transportation between therapies. When dealing with low-income families, it's important to be mindful of resources and abilities and to help connect or provide them with any services that you can. Transportation and in urban versus rural populations, transportation and access to healthcare professionals, especially specialists, can be a substantial barrier for our rural families in acquiring a diagnosis as well as access, treatment, and support. Children in urban areas tend to receive an earlier diagnosis than their rural peers. This is likely due to easier access to more practitioners, service providers, and specialists. Lauridsen's 2014 study also found greater urbanicity migration after birth for children diagnosed with ASD. The authors postulate that access to services is likely a key factor in this statistic, meaning that rural families with a child with ASD move to the city for proximity to the treatment and services that their child needs. The stigmatization of ASD can lead to underdiagnosis in rural populations. Rural families also might be unaware of other services within their community that are closer in proximity for them. So considering this in our treatment, for our rural clients, transportation might be a barrier. These are some options to consider. Telehealth services. There's much research supporting the effectiveness of telehealth services or other remote options. They might need fewer days with longer hours or sessions on those days to decrease the amount of driving. There are in-home services, and they also might need assistance with transportation or transportation services. Rural families might have preconceived notions about ABA therapy or ASD, and they might need reassurance. They also might not know anything about ABA or be skeptical, in which case we would want to provide them with education and, again, reassurance. Other therapies might not be plausible due to the transportation barriers already mentioned. If this is the case, we might need to look at condensing therapies or assisting in some way with transportation between therapies. These are my references. Thank you.